Welcome to the deep dive.
Great to be here.
Today we're taking a closer look at something that can sound pretty concerning. Visceral aneurysms.
That's right.
Think of them almost like hidden weak spots, maybe like little balloons forming in the arteries, the ones feeding your really important organs, kidneys, spleen, liver, your intestines.
Exactly. It's a good way to picture them.
And our mission today really is to give you some clear, simple insights based on expert guidelines.
Yeah, the idea is to cut through the jargon.
Right, so you feel more empowered, less anxious, and, ready for those chats with your own healthcare team.
Absolutely. So what is a visceral aneurysm fundamentally?
Yeah.
Imagine like a weak spot on an old garden hose that starts to bulge out under pressure.
Okay, that makes sense. A bulge.
Yeah, a bulge in the wall of an artery supplying those abdominal organs.
Yeah.
And the main worry, the reason we're so focused on them, is that they can rupture.
And a rupture sounds serious.
It is. It can be a major medical emergency. But here's the interesting thing. We're actually diagnosing them much more frequently now.
Oh. Are they becoming more common?
Not necessarily. It's more that our imaging, things like CT scans and MRIs, have gotten so incredibly good.
So we're just spotting them when maybe we wouldn't have before.
Precisely. We often find them incidentally, meaning during a scan done for a completely different reason. Someone might be getting checked for, say, abdominal pain or something else entirely.
Wow. So you go in for one thing and find out about this hidden issue.
Exactly. And that presents a real challenge. What do you do about something potentially serious that isn't actually causing any symptoms right now?
I see. And do we know what causes them? Is it just bad luck?
It varies. Sometimes it can be related to an injury or maybe an infection affecting the artery wall. Certain underlying health conditions can also play a role, things affecting connective tissue, for example.
Okay. So you mentioned imaging finding them. If doctors are looking specifically or confirming one, what are the go-to tools?
Well, the workhorse is usually something called a computed tomography angiography, or CTA.
TTA.
Think of it as a sophisticated X-ray that uses a special dye injected into your veins to create really detailed, almost 3D-like pictures of your arteries. It gives us a great map.
Like a road map of the blood vessels.
Exactly. Now, if someone has concerns about the radiation from a CT, or maybe their kidneys aren't working perfectly, which can be an issue with the dye,
Right, yeah.
then magnetic resonance angiography, or MRA, is a great alternative. It uses magnets and radio waves instead.
So no radiation there.
Generally, much less concern about radiation, yes. And there are even ways to do MRA without any contrast dye if needed. Sometimes, for really fine detail, especially if planning a procedure, we might use catheter-based angiography.
That sounds more involved.
A little. It involves guiding a very thin tube, a catheter, through a blood vessel, usually starting in the leg, right up to the artery in question to get direct pictures.
Gotcha. So once one of these is found and you have a clear picture, that brings us to the big question for patients, I imagine. Okay, now what? Do we need to treat this?
That's the crucial question. And it's not always straightforward, especially for those incidental findings.
Right.
Now, if an aneurysm ruptures, or if it's clearly causing symptoms, maybe pain, or signs of reduced blood flow, then the answer is almost always yes. Immediate treatment is needed, like that bursting garden hose. You fix it right away.
Okay, emergencies are clear-cut. But what about the ones just sitting there quietly?
For those, the decision often hinges on a few key factors, primarily size and location. For example, for an aneurysm in the renal artery, that's the one going to the kidney. Guidelines often suggest considering treatment if it grows larger than about 3 centimeters.
3 centimeters, okay. A specific threshold.
Yeah, though that can vary a bit. But then there are some types of visceral aneurysms where the risk of rupture is thought to be much higher, even when they're small.
Oh, really? Which ones?
Aneurysms involving arteries to the stomach or pancreas area, for instance. Or one called the superior mesenteric artery aneurysm. That artery supplies a huge part of your intestines, so a rupture there is particularly dangerous.
So for those, size doesn't matter as much.
For those types, treatment is often recommended regardless of the size. The risk is just considered too high to wait.
That's important to know.
And there's another really crucial group. Women who are, or might become, pregnant.
Ah, pregnancy. How does that factor in?
Well, pregnancy puts extra stress on the body, including the blood vessels. So for certain aneurysms, like those in the splenic artery, to the spleen or the renal artery again, treatment is often advised before or during pregnancy. Again, pretty much regardless of size, because the risk of rupture increases significantly.
Wow, okay. Any other triggers for treatment?
Yes, definitely. If an aneurysm is seen to be growing rapidly on follow-up scans, that's a warning sign. Also something called a false aneurysm or pseudoaneurysm.
False aneurysm. What's that?
It's not a true bulge of all the artery wall layers like a standard aneurysm. It's more like a contained leak or hole in the artery,
Yeah.
often caused by trauma or infection, where blood collects just outside the vessel wall but is held in by surrounding tissue. These tend to be less stable.
I see. So more likely to cause problems.
Generally, yes.
Yeah.
So those often warrant treatment too. But ultimately, it's always a personalized decision, balancing the risks of the aneurysm itself against the risks of any potential treatment.
Makes sense. So if treatment is the path forward, what are the options? What does fixing it look like?
Broadly speaking, there are two main approaches. There's traditional open surgery,
The classic operation.
right, where a surgeon makes an incision, gets directly to the aneurysm and repairs it, maybe by removing the weakened section or bypassing it with a graft.
Okay.
But increasingly, we're using less invasive techniques called endovascular repair.
Endo meaning inside the vessel.
Exactly. Instead of a big incision, we usually access a blood vessel through a small puncture, often in the groin, similar to that catheter angiography we mentioned. We guide specialized wires and catheters up to the aneurysm. Then, from the inside, we can deploy tiny metal coils, kind of like back in Peanuts, to fill up the aneurysm sac and block blood from flowing into it. Or sometimes we might place a stent graft, which is like a small fabric tube supported by a metal mesh, to seal off the aneurysm from the inside and reinforce the artery wall.
Wow, that sounds much less invasive.
It generally involves a shorter recovery time, yeah. The goal for both open and endovascular methods is the same, though. Stop the aneurysm from growing or rupturing, but crucially, do it in a way that keeps blood flowing properly to the organ it supplies.
Protecting the organ's blood supply is key.
Absolutely critical.
So whether someone has treatment or if they're in that watchful waiting group, how do doctors keep tabs on things long term?
Surveillance is vital. Regular follow-up imaging is essential.
Like those CTAs or MRAs again?
Yes, typically on an annual basis, though the frequency might change depending on the situation. If we're just watching an aneurysm, we need to make sure it isn't growing.
Right.
And if it's been treated, especially with endovascular methods, we need to check that the coils or stents are doing their job and that blood isn't somehow getting back into the aneurysm sac. We call that reperfusion.
So regular checks are just part of the plan.
A necessary part of long-term care and safety, definitely.
You know, understanding all this, demystifying these hidden weak spots, it really does feel like it can shift things from anxiety towards empowerment.
I think so.
Having this knowledge helps you become a real partner in your care, asking the right questions, understanding the why behind the plan.
Absolutely. And maybe thinking about it differently, too, just knowing how these very small, often completely unseen parts of your internal landscape are being carefully monitored and managed. It might just change how you view your own body's quiet strength and resilience.
That's a really nice way to put it. It makes you wonder, what else are you ready to understand about your own health journey?
A good question to ponder.